Hi everyone. On behalf of the ADNeT Accelerator group, I would like to welcome you to today's webinar. We will be talking about influencing Bodati through dementia research. My name is Dr. Celia Fourier, and I am a postdoctoral researcher at the South Australian Health and Medical Research Institute in Adelaide. I would like to begin today by an acknowledgement of country. In the spirit of reconciliation, the ADNeT Accelerator group acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples here today. For those of you who don't know, the ADNeT Accelerator group is part of the Australian Dementia Network. The Accelerator group was formed to support and advocate for early and mid-career dementia researchers and to help develop future leaders in the field. With today's webinar, we sought to understand how research in dementia guides the development and implementation of policies to reduce the risk of dementia and improve outcomes for people with dementia and their carers in Australia. We will have three great guest speakers discussing this topic with us today. We will hear perspectives from Mr. Robert Day from the Australian Government Department of Health, from Mr. Glen Rees from Alzheimer's Disease International, and from Psychiatry Professor Henry Brodaty from the University of New South Wales. Without further ado, I will now let Dr. Stephanie Wong introduce our first speaker.
Okay, hi everyone. I have the great pleasure of introducing Robert, who is the Assistant Secretary of the Dementia, Diversity and Design branch in the Commonwealth Department of Health. So Robert's had extensive experience in the Australian Public Service, as well as in volunteer roles in a variety of community organisations. And so Robert and his team are responsible for things from dementia policy and research, a number of different dementia-specific community programs, as well as measures to support the aged care sector and programs which support people in accessing the aged care system. So we've invited Robert here today to share his insights from, I guess, the government and dementia policymaker perspective on how we can use our dementia research to kind of engage policymakers and influence policy as well. So I'll get Robert to start sharing his screen now and turn his camera. Thank you.
Great, thanks very much, Stephanie. Hi everyone, really great to be with you for the conversation today. Hopefully I can share some useful insights with you. I guess to give a little bit more context to the introduction that Stephanie gave me, I've been in the Australian Public Service for almost 20 years now, and only 2 years of that have been working in this current role of dementia, diversity and design. I think there's a couple of things to call out from that in terms of the conversation today. One is the fairly quick turnaround of the roles within the public service. I think it's true in state and territory governments as well, that you do often find that you're dealing with, or those of you outside the public service will find you're dealing with a bit of a revolving door of bureaucrats and ministers. And I know that then makes it challenging in terms of having some of these serious and long-term policy conversations that we need to have. I think the other thing to take away from that is that I'm by virtue of the types of roles that I've had a generalist. My background is in public policy making in the way that government systems work, and I'm not a dementia expert or even necessarily an aged care expert, other than what I've learned on the job. There are both pros and cons, I think, to that. I don't have the detailed specific knowledge, but sometimes working in government does mean needing to balance different perspectives or bringing together expertise from different fields and finding a solution that marries up what those different perspectives bring. And so that's sort of the type of conversation when you're talking to to public servants, often you'll be talking to a generalist who'll be trying to balance multiple different perspectives and multiple different disciplines in coming up with a policy solution. And I think the final thing to acknowledge in terms of that background of myself is, to the extent that I now know about dementia, I am very much indebted to researchers and advocates like Henry and like Glen and like many of you, for the knowledge that I have, whether it's through reading the work that you do, participating in seminars where I can hear what you're thinking and what you're doing, and even in some cases the chance to sit down with you and talk about the work that you're all doing. So I genuinely do both recognise and value that insight that the research community has given me in trying to do this role in dementia. I thought what I'd try and do for you today is talk to you a little bit about the policy making context, how we go about doing that, and from there go into what that might mean for those of you who are researchers trying to influence the policy conversation. And I'll tell you a few stories along the way of things that have gone well and not so well over my time. As a bit of a spoiler alert, unfortunately, there is no one single answer. There's going to be, there isn't one person you can talk to or one thing you can put in your research paper that will assure that your research or your idea will be implemented. But hopefully I can at least give you a bit of a sense of the environment that you're engaging with when you try and make that translation from research into policy practice. This first slide I've got for you is the theoretical model of the public policy process that I was taught, both as an undergraduate and as a master's student in public policy. And I think it was most recently updated in 2013. And although it's a cycle, it is a fairly linear process from the starting point of identifying an issue through to analysing the problem, analysing what the solutions might be, thinking about what a policy response might be, consulting on that, reaching a decision, and then implementing, evaluating, and going back to the start of the process again. And I think in that kind of model, it's a little bit easier to see where research might fit in. It does very much fall into that identifying issues and policy analysis phase of the process. The reality, though, is that it's much messier than that. I don't think I've ever yet had a nice, straightforward policy process. And there's a range of different factors that will play into both whether a policy issue is going to be considered by government, but also then how the process is to come to a policy solution plays out. This is probably not, in fact, I know it's not a comprehensive summary of those on the slide, but gives you a little bit of a feel of sometimes the need for a policy response will be a crisis or a media story, and suddenly a minister wants to have a solution or a response they can announce quickly. Sometimes where we get to in terms of policy outcome will be driven by what stakeholders are saying to a minister, what lobbyists and peak bodies are saying. Sometimes, although there might be a really strong case for a particular action or a particular policy decision, government won't go that way because they are managing multiple competing priorities, whether that's in terms of how much money they've got to spend, or in terms of wanting to do multiple policy things and only be able to do one or two of those at a time. And sometimes I think those competing priorities aren't always really explicit. I think a really good example, a troubling example for those of us that have been in the public service was in Kevin Rudd's government when we had the roof insulation, the green bats scheme. And the public service was very much focused on the policy priority of government at the time to get money out the door and get roof insulation bats installed in as many homes as quickly as possible. And public service ministers didn't think about some of the unstated competing, not even competing priorities, joint priorities around wanting to do that safely, wanting to do that in a sustainable way. And so needing to know that there are going to be multiple things that are weighing in a decision is important for those of us that are bureaucrats, but also for people who are wanting to try and influence that policy conversation. I think for me, what that means, what that messiness means, is a couple of things. It does mean that a number of different factors are going to need to align in the right way in order for policy change to happen. It means that the final policy position is likely to be a compromise of multiple perspectives and multiple considerations. And for people like me that are working in the policy space and in policy development, one of the things I think we need to do, one of the implications for us is we can't wait until the minister asks a question about how do we solve this problem before we start researching what the solutions might be, before we start talking to stakeholders. If we're going to do that job well, we really need to be on the front foot, be talking to people, be reading the research, be knowing what's out there before we get the policy question from the minister. And I've had sort of both ends of that spectrum in my career. I've had moments when, as an immigration official, I was really convinced one of our programs needed to change, but rather than having those external conversations, rather than doing the advanced research, just looked internally within the department to what do we know as implementers and as policy practitioners about this problem, how do we solve it? And at the end of the day, we couldn't convince a minister, we couldn't convince government that was something they needed to do something about. One of the more successful examples was, again, in an immigration context, where there had been a long conversation over a year or two of the way Commonwealth laws and Commonwealth programs interacted with family violence, both for the people experiencing family violence and the family violence system specifically. And that conversation meant that my team and I, in our area of responsibility, both knew what the research was saying, we knew what the stakeholders were saying because we've been actively participating in that conversation. What actually drove change at the end of the day was a small migrant women's organisation in the minister's electorate organising a meeting with him in his electorate office and saying, this is really important to us and this is why. That led to the minister coming back to the department and saying, I've been told about this problem, what can we do? And we were then able to say, guess what, Minister, we've prepared something for you and here it is. And that did go on to become law and practice. And it really was then, I think it really highlights the combination of factors that having the conversations with stakeholders, knowing what the research said before the problem was called out, but also needing that confluence of events in terms of the local organisation and the minister's interest to drive or to get the change achieved. And I guess one final example, just to call it out and hopefully give you some hope in the dementia research space specifically, a much more recent example, in fact, goes back to a conversation that Henry Brodaty and I had in the early part of 2020, where Henry mentioned to me that there'd been an article published that was a health economics cost-benefit analysis of a dementia respite program that he'd been involved in running and evaluating previously. I went away and I read that and was quite excited by both the evaluation of the model that had been published previously and the cost-benefit analysis. And that married up with the findings that the Royal Commission into Aged Care gave us around the way that we need to better support carers of people living with dementia out of the aged care system, the way that the aged care system and respite specifically doesn't necessarily support people well if they're living with dementia, and can in fact end up in a worse outcome for the carers of people living with dementia. And that model then formed the basis of one of the budget measures that the government announced early this year in terms of responding to the Aged Care Royal Commission. So I guess a very practical example in a dementia space of the benefit of being able to have some of those early conversations between policymakers and researchers, and the way that the research can then ultimately turn into something the government will invest in. In terms of practical implications then for those of you that are working in the research space, I think a couple of things to think about. One is, think about where your research is focused. Are you looking at big picture, blue sky, major changes to the system that's operating? Or are you thinking about incremental approaches? How can we better refine what we've already got in terms of funding and system? Both are absolutely valid, and I would never try and tell you to focus on one rather than the other. But as a policymaker, the way that I'm going to use those two things will be different. The blue sky thinking, I'll be really interested in. I'd love to have a conversation with you about it, but it will probably be filed in my "for one day when the problem comes up" conversation, or for one day when there's an appetite for government to do more in this space. Whereas I live day to day in that incremental space, making changes about how programs work together, how we use the funding we've got from government. Those are changes that we're making constantly, and there's also a really valid place for research to be validating what we're doing, or helping us refine that as we go along. In terms of tips for you in terms of engaging policymakers, my first offering would be, don't be afraid to reach out to us. The reality is that my team and I don't have that chance to read everything that's published in the dementia space, and so do really appreciate it when we hear from people who've done a piece of work that they think is relevant to us. I can't promise you what every other bureaucrat around the Commonwealth or around the country will do. Most of us, I think are usually receptive. There are some people that will be worried about, either being criticised by academics in the past, a bit nervous about you might ask for money and they don't have any to give you. But I don't think it hurts to reach out and offer, and usually I think that'll be warmly received. As a policymaker, and particularly if you're ever talking to ministers, think about what are the implications for your research. If you've done something that's been peer reviewed, as a bureaucrat, I'm going to assume that your methodology is pretty good. In fact, I'll probably take your word for it, given that that's your professional expertise, not mine. But I'll be really interested in, what does this research mean for the people that might use the service, or for the way we set up a system as a whole? So focusing on the implications part of your work is really important. If you get the chance to talk to people at a political level, MPs or senators or ministers, have a think about the language that you use. Have a look at particularly how a minister might have expressed a particular issue or a particular priority, because I find often there are multiple ways of expressing the same concept, and if you use the language that most closely mirrors someone in a political world's thinking, you're likely to get a better hearing than if you use the opposite. And so I guess an example would be this current government, when they talk about aged care, talks very much about respect and dignity and giving people within the system choice and control. And if you pick that language up and use it, you're more likely to get a constructive conversation than if you go in with a the market model's wrong kind of language. Even if you end up talking about the same principles and the same putting the person at the centre of the system, one form of language may put a policymaker on the back foot, the other might get them engaged in the conversation. And I guess the other thing, if you're particularly focused on work that's going to support the aged care sector specifically, one of the challenges we have is that such a large proportion of our workforce are not university trained, and that actually then means needing to communicate what we know in terms of research and best practice in different language than we might do if we were talking to doctors or tertiary trained nurses. Very quickly, because I know I'm pushing time, I was asked to give you a sense of what my big questions are at the moment. And in terms of dementia, these are my big four. One is around timely diagnosis. What can we do, both in terms of the big picture stuff like biomarker testing, but also in terms of the the really operational, how can we get health systems to work better to give people a timely diagnosis. I think there is still more work to understand what the post-diagnostic pathway for someone with dementia could be, should be, how we can better support people to live the best life with dementia. I'm really interested. I know we don't yet do a good enough job providing equitable access to the full range of diverse groups with our dementia programs. So how we can get better in that space, I think, is really important. And finally, one of the things that the Royal Commission told us in the department we didn't do well enough is knowing and understanding how much the people that are using aged care services, how much people are using dementia services, what their experience is. We've tended to focus on engaging with providers and engaging with peak bodies. And I'm really interested in where there's a chance to learn from the conversations that you as researchers have had directly with the people accessing the services. It's obviously not the whole of the solution, but I'm also conscious that we don't want to go and ask the same person 10 different, the same question 10 different times. So how we can better learn from the insights that we've had from those direct engagements, I think, is a really interesting question for me as well. I will stop there and let's definitely move us on to the next part of the conversation. But just on that final slide, there are my contact details. So to go back to one of my earlier tips, don't be afraid to reach out if you've got an interesting piece of work you think I'd be interested in hearing about. Thanks very much for your time.
Great, thanks for that, Robert. And just a reminder to everyone else, if you have any Q&A, or for the Q&A session, if you have any questions, please post in the Q&A box. We'll move to the questions at the end after we've heard from Glen and Henry. Okay, so next I'm introducing Glen Rees, and a little bit about his background. So he's worked at senior levels in the British and Australian public services. Glen was previously CEO of Alzheimer's Australia from 2000 to 2015. And during this time, dementia was named as a national health priority area in Australia. He then moved on to be the chair of Alzheimer's Disease International until 2021. And during this time, the Global Dementia Action Plan was adopted by the World Health Organization. So Glen is currently an honorary vice president at Alzheimer's Disease International, and this is an organisation which works to advocate for better policy at the international as well as regional levels, while also supporting and developing the capacity of the various Alzheimer's associations throughout the world. So without further ado, I'll just get Glen to switch on his mic and camera. And I think Edwin is going to share the slides. Yeah, okay.
Right, thank you. Thank you very much for the invitation to talk today. I've had 35 years of experience in policy, both in government and in NGOs, and I hope some of what I've learned over that long period is helpful to those of you thinking about research and public policy today. Slide, please, Edwin. So I was asked 3 questions, and this is the first of them: how to engage policymakers. Communication is obviously essential, but really, as Robert has said, it has to be strategic. And it also requires energy, and it also requires huge commitment, brevity and focus. When I'm training people to be an advocate or talking to government, I say, have 3 dot points and stick with them, because otherwise you lose your audience very quickly. Remember too that policymakers work within a political agenda, so you have to prioritize issues and questions. And policymakers in departments are going to be governed by what the political agenda of the day is. And equally, NGOs will have their own policy agendas. Alzheimer's Australia and now Dementia Australia have had an incredibly strong commitment to research over a long period of time. Engage the policymaker in the research question. In all the time that I was in government and in NGOs, I can't recall a time when a researcher came to me before seeking funding to say, is this how it would be useful to shape the question? I really think more often, especially in respect of dementia care. Researchers should talk to policymakers, talk to service providers to make sure the research is relevant to cost constraints, service delivery structures. In so many things that are important in dementia care today, and Robert has mentioned some of them, research is only going to be successful if it's relevant to implementation within very complex systems. So if you're thinking about diagnosis or post-diagnosis, if you're thinking about carers, you should be very much aware of what the system constraints are of introducing change and making sure that your research involves economists and system change analysts. Be respectful. Politicians and bureaucrats are not always popular, so make your language nice. Send new publications by all means, but I think it would be useful to actually allow policymakers to have access to university libraries and databases and literature on an ongoing basis so that they can actually research for themselves. Slide, please, Edwin. Get on to departmental consultancy lists. KPMG and other consultants have made a fortune out of government policy and other work. And it seems to me a shame that more universities don't do the same, like Wollongong, for example. Some research agencies have involved former bureaucrats in their work. Mike Woods, for example, at the Centre for Health Economics Research and Evaluation at UTS. Prioritize policy areas of your interest, as Robert has suggested. Run policy workshops in health so you can meet lots of bureaucrats at one time. I found that very useful in talking about dementia prevention, for example, because it involves so many different bureaucrats within the department. Engage parliamentary committees. They're always interested in getting submissions, and you should perhaps make contact with them in a general way to find out what they're interested in researching and whether you can be of help. So in summary, it seems to me you can strike a balance in the relationship you want with policymakers, whether in government or with NGOs, in terms of maintaining your academic independence, seeking partnerships with government and NGOs, or seeking consultancies. Slide, please, Edward. So you can represent that kind of balance in this diagram. And of course, there are many shades of gray between them. There's no black and white rule in any of this. You must strike the balance that seems right in terms of the issue and the people you're dealing with. Slide, please, Edwin. So the second question I was given is, what makes a policy paper useful? Well, I'd say first that establish a relationship and policy papers will follow. So focus on the relationship. Too many perhaps walk in a door seeking funding as their first contact. Please don't do that. Robert has emphasized, I think, the messy nature of policy. I would put it slightly differently, but I'm making the same point. Policy is not an intellectual exercise. It's politics, it's experience, it's service structures, it's situational analysis, and its personalities. The first contact I had with dementia was in 1986 through Professors Tony Jorm and Scott Henderson, who wrote Dementia in Australia for the health department. It laid the basis, the evidence basis for advocacy to this current day. That's 35 years on. It provided the basis for statistics on incidence and prevalence, which have been the hallmark of advocacy. Tony Jorm suggested to me in 2001, when I became CEO of Alzheimer's Australia, that he would write a short position paper for me, stating the case for dementia to be recognized as a major health issue. It was the most important thing that has ever happened to me in terms of aged care and dementia, because it set out in a simple frame all the things that Tony knew and I could not possibly know as a bureaucrat. It was an object lesson in how researchers committed to their work can influence media, politicians, and policymakers. The publication of that short 4-page paper had every television station and radio station on my doorstep to talk about dementia and what is it I wanted in terms of access to care for people with dementia. The Access Economics report followed in 2003 on the social and economic impact of dementia. It really used all the intellectual capital of Jorman, Henderson and others, but I could not interest an economics department of any university in the project. So Access did the report, the Howard government loved it, and the end result in 2004 was $340 million over 5 years for dementia care. New slide, please, Edwin. There are many other examples which you can read about on these slides as we're getting slightly short of time, but I will mention Anna Howe and George Preston, who had an essential research question relevant to policymakers in the middle 1980s, which was, are the wrong people in nursing homes? A simple question, which provoked other questions about, well, if not nursing homes, what are the community options that are a possible alternative to nursing homes? The work was taken up by the Macleay Committee in Parliament, was taken up by the department in an 8-year programme of aged care based on a review of nursing homes and hostels, which I chaired within the Department of Health and Ageing. I'm not sure the department would be trusted with a review of that kind these days. Everything seems to be external. There's the seminal work of Henry Bodati that I will leave for him to talk about himself. There was the very practical work of Mike Bird at the ANU, looking beyond the symptoms of dementia to the importance of psychosocial care and teaching consumers about dementia and art, about the difference between causes and symptoms of dementia. Slide, please. There are many others who contributed. Researchers produced from left field a wonderful paper on the prevalence of dementia in Indigenous communities, which was incredibly helpful to advocacy in the work of the department. Kathy Eager has done great work on case mix and on the care component of residential care. John Braithwaite has done wonderful work on the quality of standards of dementia care since the early 1990s. Slide, please. I was asked to touch on what is it that ADI is researching. Let me make the point that ADI has one research officer. We want to avoid tokenism. So many people approach us, the problem is deciding who to partner with. Currently, we work across 16 different countries in 8 research projects. There are another 14 in the pipeline. We have one policy officer, as I've said, with others helping to manage projects as we go along. New slide, please, Edwin. These are some of the research projects we're doing at the moment. Perhaps one of the most important is the first, which ADI is doing in partnership with LSE and universities in 7 countries on models of dementia care in low-income countries. It touches on research into prevalence, interventions to reduce stigma, support for carers, pathways, stimulation of cost models. There's a strong focus at the moment on dementia diagnosis and post-diagnostic care in the Cognizance project, which Henry is leading, and in 2 World Alzheimer's reports, 2021 and 22. There's a cognitive stimulation project in Brazil, India, and Tanzania. I'm leading a project in Qatar on a national palliative care project with Dr. Stephen Connor from the Worldwide Palliative Care Association and SANAD, a Lebanese palliative care organization. We're looking at empowering carers through virtual support in Vietnam, New Zealand, and Australia. We're involved in looking at technology with young researchers. We're involved in the Worldwide Finger and Global Brain Institute work on dementia prevention and brain health. And we're involved with the World Health Organization in looking at the human rights of people with dementia through a project at Newcastle University in the UK. So thank you again for the invitation to speak to you. Remember that policy advisors and NGOs have as much to gain from working with researchers as researchers have to gain from talking to policy advisors and NGOs in promoting their work. Thank you very much for your attention.
Great, thank you very much, Glen. Okay, so that's a great segue to introduce Science Chef Professor Henry Bodati. So Henry is a researcher, clinician, policy advisor, and strong advocate for people with dementia and their carers. So I think a lot of us have probably come across Professor Brodaty already, but at UNSW in Sydney, he is a professor of aging and mental health and co-director of the Centre for Healthy Brain Aging and director of the Dementia Centre for Research Collaboration. His extensive experience in over 500 publications and his research in dementia has spanned from prevention and risk factors all the way to improving diagnosis and management, improving quality of life in people with dementia and their families, as well as reducing behavioural and psychological symptoms of dementia. So based on his very extensive experience, we've invited him here today to speak to us, I guess, from the researcher's perspective on how researchers can engage with policymakers in dementia research. Okay, so over to you, Henry.
Thanks, Stephanie. Can I just check you can see my slide?
Yes, yes.
Great. All right. So it's a pleasure to be here, and thanks for inviting me. I think it's critical that researchers are involved in trying to influence policy, and you've heard some great talks from Robert and from Glen. So I'll just tell you about some of the projects that I've been involved with and what I see as the learnings from these. So probably one of the first research projects I ever did was doing a survey of members of within ADNeT, Alzheimer's Disease-Related Disorder Society, New South Wales, and asking carers how they found the diagnosis process had occurred. And they were very critical, really. They said they weren't giving any much information about diagnosis, virtually none about management, and zero about prognosis. And so we then went and thought, well, what's the GPs think about this? And we did a survey of, I think, 1 in 5 Australian GPs. Got a good response rate. I think they hadn't been bombarded as they are now. This is back in 1994. And they said, well, what's the point? They didn't have the time, they lacked the skills, and so forth. So one of the things we then developed, so we identified a need and developed an instrument to make it quicker for GPs. So it is called the GP cog, and we've evaluated it quite rigorously, and we showed that it did just as well, it's slightly better than the midi-mental state. It's been translated into 22 countries, 22 languages, sorry, and validated in about 6 or 7 countries. And so I think the message from here is you find a problem, then try and find the answers. So the problem was from the carer side, but we want to find out, well, what's the problem from the GP side? Well, it has quite a bit of currency. It's used quite a lot, but in recent years, the mocker has taken over, and I fear that we're not going to be able to sustain ourselves. But it's certainly popular in many countries, and as I said, well translated. The other area I was interested in was in carers, and we did a lot of research showing that carers were stressed, depressed, and burdened, and that they were a major factor in keeping people with dementia living at home. And at the time, I was the superintendent of the psychiatric unit at Prince Henry Hospital. And it was an amazing thing. We had a shortage of patients. We had empty beds. And there was a program that had been run at the hospital by Gavin Andrews for stuttering, which was a residential course. And I thought, well, I used some of his techniques and devised the course for dementia carers. It was a 10-day course. It was 1 weekend. And we showed that, there it is. We showed that it reduced carer stress. And then we followed people along, and we showed that it was cost effective, even though we did it as a residential course in the first 3 years. Back in 1991, it was saving about $6,000, I think Australian per couple. And then we did it like over 7-year follow-up. We showed that it was reducing nursing home admission. And the odds ratio was 5. So where the carers had gone through the course, the person with dementia had 5-fold less likelihood of being admitted into a nursing home. Now, sorry. So that morphed into Living with Memory Loss program, which Alzheimer's Australia, New South Wales initially, and then more generally, ran across the country. And I'd just like to highlight Glen's contribution and the importance of working with community groups, with patient groups, with advocacy groups. For me, it's been one of the most rewarding aspects of my whole career, is being part of the Alzheimer's movement, statewide, nationally, and internationally. It's really, you can reach so many more people through an organization than you can as a single clinician or with research. So I'd just like to highlight that. That's one of the big learnings from there. And that was in 1985 to 87, so it was a long time ago. And then about 5 or 6 years ago, Meredith Gresham, who was the coordinator of the program, she was a newly minted OT at the stage, said, can we do this program and combine it with respite care? And she called it going to stay at home. And Robert mentioned this in his talk. And there was a 1-week admission for respite, but with the carer in groups of, I think, about 5 couples. And the carers had some training, much based on the carers program. There's a cut down version of that. And it wasn't a controlled experiment. It was a comparison against previous admissions for respite. And we showed considerable delay in nursing home admission versus comparison group. And then unbeknownst to us, Susan Dyer and colleagues in Adelaide did this cost benefit analysis. And they said, well, if we had this program going, we would be saving Australia $100 million a year. I mean, that's an astounding figure. And of course, Robert was very taken with it, as were we. And we were very grateful for it. And then, as mentioned, in the May budget, $31 million was allocated over 4 years for respite care combined with carer training. A fantastic result. In fact, I think the best result we've ever had. But what do we take away from this? The importance of having regular contact with bureaucrats. Now, we set up a meeting with Robert's predecessor about 2 years ago now, I think. We have a quarterly meeting where about 3 or 4 of us meet with the department and the relevant branches of the department to talk about what's happening in research and also to hear about what's happening in the bureaucracy. So it's a two-way conversation. Only an hour every 3 months. It's not a great onus, but it's been wonderful for us and obviously it's had results. And it's so good to hear Robert talking positively about it. So this was in the early 2000s. You know, we established our old age psychiatry department in 1990. And we were getting a lot of referrals for behavioural and psychological symptoms of dementia or BPSD. And it was a mess because the Commonwealth said, we look after aged care. The state said, we look after mental health. So if you're an older person with a mental health problem, the buck kept passing between the two jurisdictions. So I think it was on a plane somewhere. I sort of devised this model. And I came back and we spoke to Brian Draper and Lee Fei Lo, we were working together, and we wrote this paper on this 7-tier model for organising BPSD from the ground up, so no dementia, to dementia, but prevention of behaviours, which we haven't paid much attention to, and I'd like to do more on that. I had a grant to do it, but didn't get up. To mild BPSD, and we estimated the prevalence, and they were really estimates. And on the left-hand side of the slide, on the right-hand slide, we showed who should be responsible. So, you know, mild BPSD could be in primary care, and as we go up the triangle, different groups can be involved. And people can rapidly move up or down this triangle. Somebody gets a urinary tract infection, delirium, their behaviours escalate, you treat it properly, and they come back down again. But this model has been really influential. It almost seemed like the bureaucrats needed some way of tackling this issue. They didn't really have a good grasp of it. And this was a simple thing. It was, I think, a 2 or 3 page article in the Medical Journal of Australia, and it's had a major influence. It's been adopted certainly in New South Wales, and I think other states, I'm not so sure about that, and by the Commonwealth. So the DBMAS and severe behaviour response teams were set up to mainly look at levels 4 and 5. And just in the last year, and Robert's been critical for this, has been the rolling out of the Dementia Special Care Program, including 8-bed or 9-bed units in each primary healthcare network. And that really targets level 6. And the last year, I've been working with New South Wales Specialist Mental Health Services for older people, because they've been devising a policy for extreme behaviours. That was level 7. We thought there should be one unit for this, for the really violent, usually aggressive men in their 60s and 70s, often with alcoholic brain damage or some other thing like that. But they're saying that's not really going to run, and they're probably looking at a distributed model rather than enhancing within each local health district. But the point is, it provided the framework. And again, it highlights the importance of helping policymakers find solutions and trying to overcome it. So identifying a problem and then thinking about the solution. Now, in 2003, we published a study which was a randomized controlled trial of risperidone versus placebo for aggression in people with dementia in nursing homes, Alzheimer's or vascular or mixed dementia. And we showed that risperidone was effective in reducing aggression. Placebo wasn't bad, by the way. Just the extra attention reduced the aggression too, but the risperidone was significantly better. But our unexpected finding was a high rate of stroke in the risperidone group and 0 in the placebo group. And that led to a whole lot of companies, all the companies looking at their antipsychotic databases and finding increased risk of death as well. And there was outcries and black box warnings against antipsychotics. And then this is Mark Butler, who was the only Minister for Aging I've met, who said he went into politics so he could become Minister for Aging. He was a union official for aged care in South Australia, and he was very dedicated to it. And I enjoyed working with Mark. And this is a picture of him because he went on, I think it was Q&A or one of those ABC programs, and there was a lot of media attention on the dangers of antipsychotics. And there was a grant opportunity through the department. It was called ACCIHAG, was the acronym for it. And we put in a grant to de-prescribe antipsychotics. Having got the grant, the money to do the study prescribing it, now we want to de-prescribe it. And so we did the HALT study, which was halting antipsychotic use in long-term care. The ACCIHAG rules were you couldn't do a randomized controlled trial. So we did a single arm study, but we did a before, 1 month before, and then baseline, and then follow up over 12 months. And this was in 23 aged care facilities in New South Wales. And what we showed was that of the 136 who got to baseline, 124 at 3 months were off antipsychotics or at very reduced doses. And so it's about 85%. And by 12 months, we had 75%, actually it's a bit wrong there, 75% of people still off antipsychotics. And this was through academic detailing for the GPs, training a nurse champion in each nursing home to help train the nurses about behavioural management, person-centred care, and also having community pharmacists involved. And even though the people were off their antipsychotics, the behaviours didn't change. So here you see the behaviours, the NPI total score across the 12 months, and it's almost identical the whole time. It didn't make a scrap of difference. Now, Robert mentioned the Royal Commission. So that came out of the Four Corners program about the terrible abuses we all saw in aged care. And there was recommendations in the report, which came out in March this year and October last year as well, the original interim report against chemical restraint. Now, the Commonwealth set up an aged care advisory committee. It was initially chaired by Brendan Murphy, the now the Secretary of the Department of Health, but then the Chief Medical Officer, and has continued. And it came up with some recommendations about limiting the amount of prescribing, 12 weeks on the PBS, And also it led to the National Prescribing Service doing an education program for GPs. And I was delighted when they contacted me because they were interested in our program that we'd done on HALT. And so we had a GP on our team, Alan Shell, we had a nurse, Lynn Chedworth. And so we were all involved, we were talking to the NPS, and they're now doing this academic detailing of GPs. So again, research translating into action and actually making a difference. In 2012, we were asked by the Commonwealth to update a clinical guide to management of BPSD. So the DBMAS had been formed, the Dementia Behaviour Management Advisory Services. And so we did a vast literature review and published this as a print version. We published it online. Of course, we had apps, both for Android and for Apple. And it was very successful. And people called it the Bible, and it was used by nursing homes, it was used by clinicians. We had a pocket guide, and we had a larger format guide. And it was all doing well. And then Apple changed the operating system, and then we have to update our apps, which we didn't have any money for. By then, we had no money for that. So, so I kept saying in this committee, look, we've got all all these resources, and we're ready to we're in the process of updating them. We started doing a literature review again, and we actually got a grant this year from the Commonwealth to update those. So that's underway. We hope to finish it literature review this year and get busy with the consultation process and getting it out next year. In the meantime, New South Wales Health had also a handbook for management of behaviours. I wasn't involved in that. Brian Draper, Chanika Wisharatni led that. And that was in 2013. And they said, really, we need to update this. And so I think they knew that we were doing this for the Commonwealth. They asked us to do it for New South Wales Health. Their budget was much more modest than the Commonwealth, and it's on a shoestring, but we're doing that as well. So what's the message from this one? Well, I think some of it's luck. You know, I was in the right place at the right time. When we did that risperidone trial, we didn't know what was going to come out with the side effects, but we did see that there was a problem with continued prescribing, a lack of deep prescribing, and now we're putting guidelines in this. And the management really highlights the importance of non-pharmacological management. And we provide the evidence. It's really evidence-based. We've got the quality of the evidence and the strength of the outcomes. So that will be coming out next year, the update on that. The current one's still pretty good. So I'm going to finish there, but I just want to give you some examples from my department at the School of Psychiatry at UNSW that I heard about at one of our school executive meetings. So this is Susan Rees, and her shtick is gender-based violence. She's very passionate about it. And, you know, it's a common problem. It's getting a lot of publicity. Grace Tame is the Australian of the Year. There's a huge impact on women, particularly younger women. And it's a larger risk to health than many other well-recognized risk factors. So Susan, really passionate about this, and she gave a talk at a public health forum at UNSW. Colleagues contacted her. She formed a UN, and they got together and formed the UNSW Faculty of Medicine and Health Center for Prevention of Violence against Women and Children. And they set up an agenda. They wanted to do more research, teaching, and activism. And one of the things they did was, let's review the curriculums. How much do our medical students know about this sort of violence? Just disconnecting that phone. And they found out there was low knowledge. So now they managed to get gender-based violence into the curriculum of medicine. So here's activism at play. And the final example is another colleague of mine, Professor Valsamma Eaton. She's a professor of child psychiatry. And in the New South Wales budget recently, there was $109 million over 4 years added for child psychiatry. And this was to established 25 safeguard teams across the state to provide specialist mental health support to young people experiencing severe mental health and to their families. And I asked Elsa, well, how did you do it? What were your secrets? So she said, okay, here we go. And I think these are great points. 7 tips. You need to meet the other party at their burning platform. If they're not interested, forget it. You need to find out what they're talking, what their points are, what their crisis is. Second one, you need to back up your argument with specific data. They went to the department and said, or I don't know where they went, and they said, you know, there's huge problems with mental health now with COVID, and you know, people are coming to emergency departments, there's more suicides. The department said, if you look at the numbers in the emergency departments, there's no increase. And the suicides, there's no increase. So the child psychiatrist said, hang on, break it down by age. And when they broke it down by age, they saw there was a huge increase in children, young people with dementia. Sorry, with mental health problems. I've got to get the dementia off. Yeah, okay. So specific data is really important. Third thing, and we heard that from really everyone so far, you need the consumer voice. Glen taught me, when you go and see a politician, have a researcher, have somebody who knows the ropes like Glen, you know, a bureaucrat or a CEO person of an organization, and have a consumer. And the consumer voice is certainly the most powerful. And so they were able to say, look, there have been 4 suicides of young people in one rural community in New South Wales. The fly-in, fly-out psychiatrist who used to come hasn't been able to come because of COVID, and flights are no longer running. You know, they really made a very powerful argument. Now, there's no point in going to anyone with a problem unless you've got a solution. So you have to have a clear solution. And make sure you've done your background work. Do other people within child psychiatry buy into it? Do other people in the dementia think we should have, I think we should have navigators or key workers for people diagnosed with dementia. And so we need to get the legitimacy and having one voice on this. And that's where, when Alzheimer's was state-based organizations, when it came together as a federal organization, it was much more powerful in advocating to the Commonwealth. 6th point is practical implementation. You can have the best idea, it can be a burning issue, but if it can't be implemented, then you've got a problem. And I think one of the, strokes of genius that Glen did is he did that economic modeling. And that really convinced the government that spending $1 would save more than the $1. So there was a great return on investment. And the final point is, give them something they can crow about. Because if a politician can have an announceable, have something that makes them look good, leaves a legacy, they're much more likely to embrace it. So thank you, Elsa, for those 7 tips, but I think they're really helpful. I'll stop there. Oh, sorry. One important questions. So the 4 important questions for me were risk reduction, and we're doing a Maintain Your Brain trial. Dementia in hospitals, we haven't talked about that. That's not part of the Roberts bailiwick, but it's an important issue because we know 1 in 4 people with dementia will go into a hospital in a year and they have a worse outcome. Implementing person-centered care, making it business as usual. And I'm trying to work up a project on personalized approach to BPSD. We know about personalized medicine, general medicine. Can we use the same principles? It may not be pharmacogenomics, but can we use the same principles for BPSD? And at what stage should you be involved in the research? Definitely you should be involved pretty early on, but not at the very beginning, not when it's just a light bulb in your head. When you've got something a bit more, I think, when it's practical and when you thought about the budget implications. And when you're ready, check to see that it's feasible and check to see that it's of interest. Thank you.
Thanks very much, Henry, for the excellent presentation. I see now that we're just at 2 o'clock. Do we have any sort of final questions or quick questions for these speakers? I think Glen, Robert, and Henry gave a really comprehensive sort of overview about the sorts of issues that we as researchers face and the sorts of strategies we can employ when engaging with policymakers. So I think I'll just have a quick look at the Q&A. Otherwise, I think you guys actually answered all the questions we were after. I thought you'd summarize some really handy tips for, especially for early and mid-career researchers who are kind of, I guess, at that stage where they're thinking about how they might go about approaching policymakers. But yeah, thanks so much for the sort of summarizing those tips for us. So if there's no sort of immediate questions, what I might do is if people have questions, is it okay if they send you an email and reach out to you? Yep.
Sure. Sorry, I didn't put my email on the slide, but very happy. Yeah.
Yeah. So we'll be posting this recording up online, and we can provide your contact details to the audience as well.
Yeah.
So I really just want to thank you guys for excellent presentations. It's been very insightful.
Okay.
Thanks very much.
Can I just say, if you do email me, don't spell my name like it's on the screen. There's an extra R in there that shouldn't be there. So it's Brodaty. Yeah.
Yep. Okay. We'll make sure to correct that.
Okay. Thanks.
Great. Thanks, everyone. Bye-bye.
Bye.
Thanks very much. Great to be part of it today.
Thank you.
Good to see you, Robert and Glen. Bye.
You too, Henry.